Hey everyone, and welcome. This explainer comes to you from the Surgical Edge podcast. Today, we're diving into something every one of us sees on the front lines, rectal bleeding. It's common, it can be scary, and the big question is always, who needs to stay and who can safely go home? We're going to walk through a really slick, evidence-based way to make that call. Let's jump right in.
Okay, before we get into the nitty-gritty, we have to get the standard disclaimer out of the way. And it's a super important one. Everything we talk about here is for reference, for educational purposes. It's meant to give you a solid framework, but you always, and I mean always, need to follow your local clinical guidelines and protocols. That's not negotiable.
All right, let's set the scene. You know the drill. It's a busy shift. A patient presents with rectal bleeding, and right away, that clock starts ticking. The big question in your head is, okay, who do I need to admit right now and who can I actually send home safely? It's a huge decision, right? The stakes are high. Well, we're going to give you some really powerful, simple tools to make that decision with confidence.
So here's our game plan. First, we'll touch on why this presentation is such a common challenge. Then, we'll walk through those essential first steps of assessment. After that, we get to the really cool part, the game changer, risk stratification. And once we've got that down, we'll look at how it creates a clear pathway for intervention. And finally, we'll talk about the payoff, why this modern approach is just better.
Okay, so let's dive into the challenge itself. The thing about rectal bleeding is it's super common. We see it all the time. But the cause? Man, that could be anything from something pretty minor, like hemorrhoids, all the way to a life-threatening, massive diverticular bleed. That huge range is what makes it so tricky. And this huge list of possibilities creates a real puzzle, doesn't it? I mean, the number one cause is diverticulosis, those little pockets in the colon wall. They can cause some pretty dramatic, though often painless bleeding. But then you've got this whole laundry list of other things to think about. Angiodysplasia, colorectal cancer, IBD, ischemic colitis, even something as straightforward as an anal fissure. When your differential is that wide, you absolutely need a structured way to think about it. Which brings us to our next section, first steps. So with all those potential causes swirling around, where do you even start? Well, you start with the basics. It doesn't matter what you think the cause is just yet. Every single patient needs a solid, systematic workup. This is your foundation. Get this right, and everything else falls into place. And that foundation is built on 3 pillars. Number 1, a good history. Really dig into the details of the bleed, any other symptoms, and especially comorbidities. Are they on any blood thinners? Number 2, a proper physical exam. And yes, that includes a DRE. And number 3, your basic labs. We're talking a full blood count, coags, and a group and saver crossmatch. It's bread and butter stuff, but you can't skip it.
Now, while you're doing that initial assessment, there's a fantastic little tool you can calculate right there at the bedside. It's called the shock index. Think of it as a quick and dirty snapshot of your patient's physiology. All you do is take their heart rate and divide it by their systolic blood pressure. That's it. It's so simple, but it is so useful for spotting who's in trouble early on.
So why are we banging on about this simple formula? Because of this number right here. If there's one number you take away from this, make it this one. A shock index greater than 0.7. That is a massive red flag. It's telling you the patient is hemodynamically compromised, they're starting to decompensate. It's your first objective sign that this patient is sick and at high risk for a bad outcome.
And that leads us perfectly into the real heart of this whole discussion. This is the game changer. We're talking about moving past just our clinical gut feel, which is important, don't get me wrong, and adding in a layer of objective, evidence-based risk stratification. And the tool for that job is the Oakland Score.
So what is this Oakland Score? Well, it's a scoring system that's been properly validated, and it was designed for one specific job, to help us with patients who have an acute lower GI bleed. And its main superpower, really, is its ability to reliably pick out the low-risk patients, the ones you can safely send home and follow up as an outpatient. Think of all the unnecessary admissions that could save.
And the beauty of it is that it's super practical. It doesn't ask for any weird, exotic tests. It just uses the data you've already gathered in your initial workup. Things like age, sex, if they've had a PR bleed before, what you found on their DRE, their heart rate, their blood pressure, and their starting hemoglobin. It takes all those key pieces of the puzzle and boils them down into one single, powerful, objective number.
And using that number is incredibly straightforward. There's a clear cutoff. If the Oakland Score is 8 or less, that flags the patient as low risk. We're talking a really low risk of rebleeding or needing any kind of intervention. These are the folks you can feel confident about sending home. But if that score tips over 8, that's your high-risk patient, and they need to be admitted, no question.
All right, so let's put it all together in a clear pathway. We've got two fantastic tools now, right? The shock index, which gives us that immediate how sick are they right now picture, and the Oakland score, which gives us the bigger picture of their overall risk. And when you use these two numbers together, you get a really clear, simple management pathway.
This really lays it all out. It's so simple. Let's look at the low-risk box. If your patient's Oakland score is 8 or less, and their shock index is under 0.7, they tick all the boxes for being low risk. You can seriously consider a safe discharge with a good follow-up plan. Now look at the high-risk box. If either their Oakland score is above 8 or their shock index is above 0.7, they're high risk. The decision is made for you, they get admitted for an urgent workup. See how clean that is?
So for those high-risk patients you've just admitted, what's next? Well, the priorities are clear. It's all about ABC resuscitation first and foremost. Get those lines in, get fluids or blood running. Fix any coagulopathy, and then you've got to find the source, and fast. That usually means getting them on the books for an endoscopy within 24 hours. If the bleeding is really heavy and you can't wait, you might jump to a CT angiogram to pinpoint the bleeder, which can then lead to interventional radiology for embolization. Surgery is really the last resort, for those rare cases that just won't stop.
Okay, so we're at the final section, the payoff. You might be thinking, okay, that's a couple extra calculations to do on a busy shift, so why bother? What's the real benefit here? Well, the payoff is huge, and it's not just for the patient. It's for the hospital system, and honestly, for you as the clinician too.
So, here's the bottom line, the why this matters. First, it makes things safer for patients. The sick ones get treated faster, and the not-so-sick ones avoid the risks of being in a hospital. Second, it's just smarter with our resources. We're not filling up beds or emergency endoscopy slots with people who don't need to be there. Third, it gives you solid, objective ground to stand on. Your decision to admit or discharge is backed by evidence, which is always a good thing. And finally, this isn't some rogue idea. This whole approach is right in line with the major British and European guidelines.
So the big takeaway message is this. Risk scores are not just for research papers or for ticking a box. They are active clinical tools. They should be calculated, they should be documented in the notes, and they should genuinely guide what you do with that patient, from the moment they walk in the door right up to that final disposition.
Look, by using tools like the shock index and the Oakland score, you're elevating your practice. You're not just reacting to a symptom, you're applying a systematic, modern, and ultimately safer standard of care. So, if this explainer was useful for you, do me a favor and share it with a colleague. The more we can spread good, evidence-based practice, the better. Thanks so much for tuning in.